So good morning, everybody. As people are starting to file in, I'll go ahead and make a start. I did want to make one announcement this morning. Getting Bill Hellenbrand here is a little easier than some people because his daughter lives here in the Twin Cities, but this is being supported by the chair that Franck Goujon donated to Pediatric Cardiology, and so that allows us to bring people in to talk. So Franck is in the Cayman Islands, of course, so he wasn't able to be here. So we're lucky this morning to have Bill Hellenbrand. Dr. Hellenbrand, I've known for some time, primarily through Kurt Amplatz' devices, I think, and in some of the medical meetings. Did his undergraduate work at Brooklyn College, did his medical school at, is it pronounced SUNY, Bill? State University of New York, internship, residency, and fellowship at Yale, and did 2 years at Walter Reed Hospital doing pediatric cardiology in the Army, was director of the Cath and division director at Yale, and then moved to Columbia where he was director of heart catheterization, and then eventually became division director of pediatric cardiology at Columbia. And finally moved back to Yale again, where he was division director from 2011 to 2015, and now just runs the cath lab and pulls strings from the background. Bill has an extensive bibliography, but over the past 10 years, I think, at least looking at his publications, has really had a focus on transcatheter valves, and that's going to be primary or part of at least his talk this morning, looking at rehabilitation of the post-operative TET patients with putting valves in and reconstructing the heart and competing with the surgeons. From my career, I spent 15 years in echo and then switched to interventional cardiology. And so we started out in echo. Basically, the role of the heart cath when I started in cardiology was as a diagnostic procedure, and then echocardiography basically supplanted the cath as a diagnostic tool. And then interventional procedures and catheterization came along, and have many cath labs, I think, are doing more business taking care of patients than the surgical programs are. So it's become a very important part of our ability to care for kids with heart disease. So Bill, maybe you can.
Thank you.
Thank you.
Thank you. Hi there. First I want to tell you that I want to thank everyone for inviting me to come here. It's always like to come to Minneapolis. I get a chance to see my grandchildren, my daughter, and then I get to meet everybody here at the university. I want to correct one thing that John said. I don't compete with surgeons for patients. I collaborate with surgeons to provide the best care that we can provide to our patient population. And I mean that very seriously, because this is what I do is a joint venture I could not do without my surgical colleagues, and they can't do everything they want to do without our help as well, both pre- and post-operatively. I am not just going to talk today about the cath lab approach to patients with Tetralogy of Fallot. What I'm really going to do today is tell you a story about, which really transcends just cardiology, about what we thought we could do in taking care of surgical patients, certain common patients with common form of congenital heart disease, how well we could treat them, how well we could operate them, and then realize 20 years, 30 years later, results aren't as good as we thought. And we need to take a much longer view of our patient population, and I'll go into the reasons for that in just a few minutes. But this is really a story about feeling that you cured something, and clearly we have not cured something, just changed the problems and made the problems when the patients were older. So, first of all, my disclosures: I'm a consultant both for Medtronic and Edwards, and I also will talk about some off-label use of devices. They asked me to provide some learning objectives, and I think you see them here. We're going to talk about the pathophysiologic states following repair of Tetralogy of Fallot, summarize the techniques that are available in the cath lab, and appraise some new therapies on the horizon. This is a very interesting slide. Not a lot of people know this, but if you look at the number of patients with congenital heart disease around the world and look at the ratio of pediatric age patients, that is up to age 18, and adult patients with congenital heart disease, if you go to the mid-80s, you'll see there are more pediatric patients than adult patients. You come now, there are probably twice as many, more than twice as many adult patients with congenital heart disease. So my cath lab is not a cath lab, it's not a pediatric cardiology cath lab. It's a cath lab for congenital heart disease, irrespective of age. We catheterize newborns up to 80-year-olds with congenital heart disease in our cath lab. And this becomes very, very important because as we follow our patients older and older, we realize we've created a new set of problems, and I think if we had gone back to the techniques we had used for the original surgery, some of these could have been prevented. This is purely in hindsight. We couldn't have known it at that time, but we can learn a lot in general about medicine in general from this. This is a really interesting slide from the Netherlands. The black line, it really represents the age of death in the general population. And on the left is the years 1987, 1988, and the slide on the right is 2004 to 2005. And the yellow ones are the deaths of patients with congenital heart disease, the ages. If you look at 87 and 88, we have a large number of deaths, much greater than the general population, the neonatal group, on the bottom line, less than 1 year of age. Almost 25% of our mortality came at that point in time. You look at 2004 and 2005, the number of deaths was still greater than the general population, but not that much greater. And you go look at the top of the slide, you can see that we really fit into the normal curve with adult congenital heart disease dying. And so therefore, we've done a much better job. That's why there are so many more patients with adult congenital heart disease around than there were before, because we've done a really good job of survival. We've done a really great job of them making it to adulthood. What we didn't expect to see is so many of the problems on the complex heart disease as they got older. And we're going to talk about that today. We're going to really talk about Tetralogy of Fallot, although it is a marker for several different types of congenital heart disease. But I thought Tetralogy of Fallot is the most common form of cyanotic congenital heart disease there is. And I thought we'd just go over some of the summary for everyone here, what it is and exactly how we manage it. What you see on the left there is the normal, where you have the four chambers of the heart, the right atrium, the right ventricle, leading to the pulmonary artery on the right side with the dark blue blood, and with the red blood, the left ventricle, the aorta, and the left atrium. And there's a total separation between the two sides of the heart. On the right side, you see what we see with Tetralogy of Fallot. Tetralogy obviously stands for four different things, and that was described by Fallot in the 19th century, showing the four different abnormalities in these patients. It's actually a single embryologic error that creates these four different problems. Do I have a pointer here, guys? Yeah. Which one? This one? Sorry, I can't get it to work. I got it. So this is the patients with the Tetralogy of Fallot. And I would just tell you that the single embryologic error was this right here, and that this is part of the septum that separates the left and right ventricle, as is this part. They're supposed to grow together embryologically. When it doesn't grow together, and the top part deviates towards the right ventricle underneath the pulmonary valve, it creates a gap here, which is the VSD, and this moving over, this muscle, causes obstruction to blood flow up here. So the two major parts of Tetralogy of Fallot is the hole in the middle of the heart and the pulmonary stenosis, the obstruction of blood flow to the lungs. The murmur you hear with Tetralogy of Fallot is from obstructed blood flow going from the right ventricle through this narrowing, and it generates a murmur of varying intensity. We all have the classical finds of children with Tetralogy of Fallot, so-called TET spells, where patients become cyanotic, hyperpneic, and they lose their murmur completely. And they lose their murmur because for some reason they suddenly decrease the amount of blood going out the pulmonary artery through the narrowing. All the blood goes out the VSD, so all this blue blood goes out into the body, out to the aorta, and they lose their murmur completely. But this is the classic example, and we used to see a lot of patients with TET spells. We hardly see them at all anymore because we really repair all these patients in the first 3 or 4 months of life when we know them, so we don't see that as much anymore. So in the repair of this, is done like this, in that one where there's a large hole right here. They put a patch, straightforward. The surgical results are excellent in the initial surgery. They've closed the VSD, and they open up the narrowing of blood flow going to the lungs. They incise the anterior wall of this inside in the operating room, open it up completely, and just place a patch on it. They also resect some muscle, but place a large patch over this. So it's so it's a patch just on the front, sort of what we call non-circumferential, just lies anterior, and that relieves the stenosis, and we close the hole this way. This is the most commonly performed between 3 and 6 months. Mortality is very low, but there's no functioning pulmonary valve in many of these patients when you do that. So that you're left with free insufficiency of that valve. And this is just a picture of what it looks like. You can see this is an angiographic picture of a large right pulmonary artery, a large right ventricle with free PI here. This is the most common repair that we see, which is so-called non-circumferential connection here. And if you go look at this is an MRI clearly showing you free, no pulmonary valve whatsoever between the right ventricle and the pulmonary artery, free flow forward, free flow backwards, totally insufficient valve, and that causes progressive dilatation of the right ventricle. That's the most common form of repair. There's another smaller group of patients who have a severe form, have the same VSD, but have the severe form of pulmonary stenosis to the point where there's no connection between the heart and the pulmonary arteries. And that usually has to get repaired by a circumferential repair. And I use that term because we're going to use that a lot later. This is a circumferential repair. This is a tube that's placed between the right ventricle and the pulmonary artery to establish a connection. And inside this tube is frequently a valve. And we'll show you what kind of valves they are in just a minute. But this is a circumferential repair that when you put it in a small child, obviously it's going to have to be replaced for size. Those connections that you see there are several different types. The most common types in the babies you see or younger kids is homographs. This is cadaveric aortic or pulmonary homographs. You can have xenografts, which are Dacron tubes with bioprosthetic valves inside. You can have artificial tubes with bovine jugular venous valves sewn inside them. These are the most common types we see. These are circumferential repairs that we see there. And what happens to those patients compared to the picture I showed you before is that these are circumferential repairs with a valve inside them, but they frequently become stenotic and become narrowed in this particular region. So you get a real area of recurrent stenosis, which is what the problem was ahead of time, but frequently you can get stenosis in there. So they can become stenotic. Occasionally they become insufficient, but most of the times they become stenotic. So we have two different types. As you can see here, we have the non-circumferential repair, which is just a patch, totally eliminating the function of the valve, removing the valve frequently in muscle. Not all the time, but you frequently get loss of valve integrity. And then you have the other type, the circumferential repair, where you've put a valve in place, but it's small, it's not true native tissue, and these almost always will fail as you go along. So this particular group of patients is the patients they talked about in the 1980s, 70s, and 80s, early 90s in the literature, saying we have repaired these patients. Pulmonary insufficiency is inconsequential, is not a problem. It's stated in the literature, stated in the textbooks. The word cure was used in the textbooks for these particular group of patients. Conventional wisdom. It's been generally thought from the 60s to the 90s that repair was curative and the consequences of wide open outflow patch with free insufficiency was trivial. It has become clear to us now, all of us taking care, especially the adult congenital heart disease doctors, this repair is very good palliation initially and bad result long term. And we've actually changed near certain death from profound cyanosis as a newborn for definable incidents now in these patients of heart failure, arrhythmias, and sudden death when they're no longer pediatric patients, but when they're adult patients. And but we're responsible for transmitting those patients up there, and we have to learn about what we've done. As I said, pulmonary incontinence was regarded as an inevitable consequence of the repair. Emphasis was always placed on complete relief of obstructions. You didn't want any residual pulmonary stenosis, so you opened up that outflow tract widely, which led to free regurgitation and a dilating right ventricle. This misguided assertion of that incompetence was unimportant is really understood. These patients were not symptomatic. These patients did great. They had children. They went through pregnancies. They did okay. When they got to the 30s and 40s, they started coming back with severe heart failure, arrhythmias, and I'll show you some other things that occurred. So these symptoms developed decades after repair, and that's why we really didn't think it was going to be a problem for that to see that. One of the problems is we don't get to see those patients when they graduate from our care and we transition them onto adult cardiologists. We got to see a lot more of these patients came back. So what are the conditions, status, post-repair of tetralogy of Fallot that we're going to talk about? There are two of them. Severe residual stenosis, which produces significant hypertension of the right ventricle. Their symptoms are usually easy fatigability, chest pain, and they occur whenever the obstruction is there. So you know when they're symptomatic. They are not the group of patients that we missed. Intervention is usually associated with relief of symptoms and improved exercise performance and allows for remodeling of the right ventricles. If that right ventricle is obstructed and if it begins to decrease its pump function, it can remodel and regain some of its pump function if you repair on in the presentation. While severe pulmonary insufficiency with volume overloaded right ventricle, over time, they decreased exercise tolerance, and it was a very gradual process. Some people thought it was normal for them to feel couldn't keep up with their peers. But when they got really symptomatic, they'd be in heart failure with cardiomegaly, arrhythmias. They have arrhythmias, ventricular tachycardia, and they have sudden death related to chronic heart failure and arrhythmias. And this became a real problem in patients in their 30s and 40s. The problem is when you intervene on these patients late, intervention is associated with some improvement in symptoms. Patients frequently feel better when you get rid of the pulmonary insufficiency in a patient who's 30 or 40. But we could not document any improved exercise performance, and we couldn't get remodeling of the right ventricle because it was so late in the process that you couldn't remodel and you couldn't come back a functioning right ventricle. We've realized this in the last 10, 15 years, and now we try to ask our surgeons when they operate now to try not to create this wide open RVOT, and perhaps we should leave more obstruction. It's not quite clear what the right answer is right now, but we're hoping, and we're going to talk about the rest of the day today, is that early intervention and recognition and how to do this intervention may improve the long-term outcome. And part of the reason for developing this technique is some of our patients who've already had 3 or 4 open heart surgeries. They don't want to come back for open heart surgeries. They don't want to do this again, and they're higher risk to go through it. So a lot of strategy is involved in developing alternative means to treating these patients. This is a paper from Holland looking at survival of Tetralogy of Fallot long term. This is cumulative survival from time of surgery. And 40 years out from surgery, we have about 70% of the patients still surviving, but are actually quite sick. And if you look at the patients, the interventions on these patients, surgical or cath lab, and this is really the pre-cath lab era, you can see that by 40 years out, 40% of the patients should have interventions, and there probably should have been a lot more. And the interventions are black line, and pulmonary valve replacement is the red line. So almost all the interventions were pulmonary valve replacements. And this is now 40 years. Now, the question is, if you have pulmonary valve out here and you do the intervention much earlier, are you going to prevent progressive disease in the patients? We don't have all the answers for the long-term prevention of progressive disease, but we do know we make them better. And we do believe that putting the valves in will functionally make them better going forward. One piece of research data I'm going to show today in animal data. I really don't want to spend a lot of time. There's a lot of work been done on this in the animal lab. But if you look at a bunch of piglets who you've removed the pulmonary valve completely and had them survive for 6 months, and they become very large in 6 months, the red curves are the patients who are the controls who have a competent valve, and the blue curves are patients who have the valves removed. It looks at the right ventricle, and the bottom line looks at the left ventricle. And you then challenge them with an inotropic agent, dobutamine. You will see in the controls, the stroke volume increases by 25% in both the right ventricle and the left ventricle. And those with chronic PI, the stroke volume only increased by 3% on the right side and by 9% on the left side. And a lot of other animal data has shown that chronic PI, and in a piglet, in a pig model, this is only 6 months, they had significant abnormal responses to inotropic agents at that point in time. So we needed to do something for these patients. And if you look at what is available, what the patient base is, these are all patients that have some abnormality of the RV outflow tract, which is what we're talking about here. That represents about 22% of all congenital heart disease patients. The vast majority of Tetralogy of Fallot, those what I told you about who have non-circumferential, non-conduit, and those a smaller group along with other patients that have circumferential repairs. So you'll see we started out dealing with the circumferential repairs because we got to see those early and we developed techniques for working on those. And we're now working on this group of patients. We have some devices to help us work on those patients. We're going to talk about timing in just a minute. And And we are on the horizon now with the FDA doing some new IDE trials, looking for new ways of dealing with these patients. One of the problems with the surgical side, that we'll get into in a minute, is whenever we put a surgical valve in, you're guaranteed to have to reoperate on those patients. So it's more and more surgery as you go forward. So what were the options prior to transcatheter valves for recurrent stenosis? You could do balloon angioplasty, or you can put a stent in there where the stenosis was. What were you creating? You're creating free pulmonary insufficiency because there's no valve there. So you're creating a model of what you don't want to create when you do that. Or you can go to surgery. And the only option prior to this approach for pulmonary regurgitation was a surgical valve. There's no other way to do it. These surgical valves, I'll show you the data, do not last forever. It's a 50% is probably about 7 to 8 years on a lot of these valves right now, especially in the post-op TETs. And I think a lot of these patients don't want to go through multiple repeat procedures. So what we used to do for obstruction is what you see here. You can see that there is the right ventricle, pulmonary artery, homograft that has become narrowed. We can put a stent in that place. You can see that right there. We're very good at that. We can put stents in there, relieve the obstruction completely. And we know in several different, these are the stents we use. We have covered stents, we have platinum iridium stents, we have stainless steel stents, we have all kinds of stents we can use in various places. We can put that stent in there, usually in a cath procedure, and relieve the obstruction. But all we're doing is creating free PI. This is just an article that came out in the late 90s about stenting the RV outflow tract from Boston Children's. We did it very well, but we then created a whole new group of patients that had PI and then progressively got ill. So what's the goal of therapy now? So the goal of therapy really is we need to restore and maintain pulmonary valve competence, and we need to relieve stenosis without the risk of regurgitation. That's what we need to do. That's what the surgeons do when they put a valve in there. They relieve obstruction and get rid of incompetence. How many times do you want to send a patient back to surgery to do this? And patients don't want to go back to surgery multiple times, especially when you get to 5 or 6 open heart surgical procedures. So along came the technique of trying to put a valve inside the heart and treat them. There are 2 valves that are out there that are currently approved for use in this. First one is the Melody valve made by Medtronic. What it is a bovine jugular venous valve. It's the jugular vein valve of a cow. Apparently, with your head down like that, walking around all the time, you need a really good valve system so your head the cow's head doesn't fill up with blood. So they have an extremely well-developed valve. Looks like a human semilunar valve. I'll show you that in a minute. We placed it on a stent, sewed it on a stent by Medtronic, and then it was implanted, and you could deliver it, and I'll show you in a minute how we delivered it. The second valve, you're well aware of the TAVRs, or the transaortic valve replacements, a big thing in adult cardiology right now to use sapien valves. And they are valves that are meant for the aortic valve, but now have been tried in the pulmonary position. And this is actually bovine pericardial leaflets that are built by the company on a cobalt chromium stent. This stent actually is a very good stent. It's much stronger than this stent. Best of my knowledge, Melodies have implanted over 11,000 cases in the world right now. My understanding is sapien, it's at least 1,200. It's not tied. It's hard for me to get the information from Edwards as it is to get from Melody. And basically, we talked about this further. I'm going to tell you the data from the Melody trial and tell you how we use it because I'm more familiar with the Melody trial, although I participated in both trials for both valves. And this is, just like we said before, this is our goals. The primary goal of the trial was to restore and maintain pulmonary valve competence and provide relief of obstruction and no insufficiency. Not too many people have seen this. This is a human pulmonary valve in a hanging heart preparation with saline, showing you what it looks like in systole and diastole. Systole it opens and diastole it closes. On the right is the Melody valve. Not quite as elegant as the human valve. We can never get there as elegant as the human valve, but it functions quite well, like a tri-leaflet semilunar valve. Just to show you briefly, they accept about 1 out of every 100 valves they receive from the slaughterhouses when they look at this because they have to be in good shape, perfectly shaped, and whatever they want, but accept about 1 out of 100. And then it's handcrafted, sewn on the stent I showed you. The bottom part is an ultrasound just showing you the valve leaflets functioning beautifully inside a pulmonary artery in a patient after they've been put in place to do that. All right, I'm going to go on. So how do we implant this valve? The valve comes like this. You can see it right here. It's sewn onto a stent, and the valve is inside there. And then the stent, this valve is placed on a catheter with a balloon on it, and it's crimped down onto the balloon. And then you'll see here that catheter, that balloon is covered with material from the catheter, so it's protected during delivery up into this region. And then down here you see a picture of a heart, which I'll put in motion in a minute. A catheter goes usually from the leg, from the femoral vein, through the IVC, through the heart, through the tricuspid valve, into the pulmonary artery area where there's a conduit or a native outflow tract or whatever repair that's there. And it's delivered, as you see it right here. It's then expanded, the balloon is expanded. It's uncovered first. It's always a good idea to uncover it before you expand it. And expand it. And then after it's fully expanded, as you see here, the balloon is deflated. That valve stays in place, but the stent holds it in place, and there you have a functioning valve. So the whole goal of this originally was really to try to delay the need for open heart surgery in these patients so they wouldn't have to go so many surgical procedures, and also to decrease the frequency of the need, how many surgeries you need in a lifetime. This is what it looks like on a patient. I showed you this patient before, that one with a narrowed homograft. We put a stent in to relieve the obstruction and then brought him back several years later when we realized we needed to not leave anyone free insufficiency, built the area with multiple stents to create a good landing zone for the valve so the valve worked well. And then you can see there's no insufficiency anymore. You inject contrast in the PA, nothing's coming back to the right ventricle, so this valve is functioning quite well, and we could do that actually quite successfully to make that happen. So this is the other valve. This is the sapien valve, just to show you an example of how this is done. This is a patient whose PA and RV is freely, no functioning valve tissue here. It's leaking. This is an example of the non-circumferential repair. The first one was a circumferential repair. We put stents in there, create a landing zone for the valve. We then can deliver the valve. You can see right here on a catheter as I move it up right inside those stents. And you'll watch over here, it's being expanded to fit right into that area. And then you just deflate the balloon and take it out. So both the sapien valve and the melody valve, unfortunately the sapien valve is not designed for the pulmonary position. It's a lot harder to deliver than the melody valve. But the advantage of the sapien valve is that it comes in much larger sizes than the melody valve. So now I can treat even the big outflow tract packs, some of them anyway. Quickly review the trials, the initial trials for approval of both these devices was 167 patients for the Melody. Edwards had 74 patients. 149 out of 150 were successfully implanted. 66 out of 68 successfully implanted. So the results are pretty much the same for both and did very, very well. I'm going to go over the results from the Melody just briefly to show you some of the complications we had to overcome. Anyone over 5 years, anyone over 30 kilograms, and any conduit, circumferential conduit greater than 16 millimeters was a candidate for this study. You had to be symptomatic, that is, you had to be New York Heart 2, 3, or 4, and with severe obstruction and insufficiency. You could be asymptomatic if you had severe pulmonary regurgitation with some dysfunction, even though you didn't make New York Heart Association Class 2. We attempted 167 patients. We brought to the cath lab. We attempted 150. 17 were not attempted because we had to learn who we couldn't do it of. This is where we learned some stuff we didn't realize was going to be a problem. We couldn't do 6 patients because every time we blew up a balloon, we were going to put the stent, we compressed or closed one of the patient's coronaries. Obviously, you can't do that. 8 of the patients, the alpha tract was too big, or we couldn't fit it in there. And those are the major issues. And then we had 149 patients out of the 150 in long-term follow-up. Every patient, we had 149 in follow-up. We had to take one out in 24 hours because we ruptured the conduit that was in there, putting it in. Now we have long-term follow-up on 135 patients. This was done between 2007 and 2010. We have we've lost the follow-up. 4 patients have died, not directly related to this procedure, but related to their heart disease. You can see here, some of the patients have been lost to follow-up, which is true for all of them. Just quickly to show you something we learned very early on. This is where we always put a balloon up first where we're going to put the valve to see what we're compressing. You can notice right here, this is a coronary artery. This is the left coronary supplying the whole left ventricle. This is what it looked like before we put the balloon up. If we had put the valve up and the stent up in here, this patient would have died on the table from a massive infarct. And here you can see severe stenosis of the coronary. That's exact time we're done, and the patient will go to surgery for a surgical approach. And this is a 7-year-old. Just will show you real briefly. I just want to show you the pictures on the right here. This is a picture of an aortogram in a patient who's had an arterial switch for transposition of the great arteries. We had to put a melody valve in because his conduit was very stenotic. This is the aortogram showing me the left coronary and the right coronary. This is the wire where the balloons can glow. We then blew up the balloon, as you see right here, and did the aortogram again, and something's missing. There's no flow down the left coronary whatsoever. Completely gone after an arterial switch procedure for transposition. So once again, we learned very early on we don't need to do something like that. The baseline demographics, I said 85% of the patients were New York Heart 234. Procedural success was 148 out of 150 patients, which is really good for a new structure. Did everything it was supposed to do. This is the degree of obstruction in patients, and pre-blue, post-red. All the obstruction disappeared, and we had low pressure and no narrowing across this valve acutely. This is the acute results. And these are the long-term results for those particular patients for relief of obstruction. These valves, this is the degree, we have no significant stenosis now out 7 years. I don't have the graph with 7 years, but I just recently saw the data for 7 years. The valve does not get stenotic with time. And that's true of the sapien valve, again, but I only have data out 1 year. Their study was much later on, so I don't have their long-term data for this. We're looking for that long-term data to come out. If you look at the biggest problem with severity of pulmonary regurgitation, before you put it in, all this orange and red is moderate to severe regurgitation. All the green is none and yellow is traced to mild. There is no significant regurgitation out 6 years now, almost 7 years out. And that's true of the sapien valve as well. It works very, very well. In fact, it works much better than any surgical valve, and I'll show you that data in a minute. In fact, the patients really feel better. So we know we can accomplish the same things the surgeon could accomplish with the same results and some better long-term results. And you can see here the patients who are only 15% were New York Heart 1, the vast majority in New York Heart 1, which is the blue. And the same thing was found with the sapien valve in the two trials. The two trials really showed the same data. We just have better long-term data for the melody valve at this point in time. Give you an example of what it looks like. And I'm purposely giving you an adult patient to show you what these patients are like. This patient had surgery at 5 years of age for the RV outflow tract, for severe cyanosis. He had repeat surgery at age 13. He was lost to follow 35 years, 30 years. He felt well. Then he started to slow down, and he came in to see us. He had an RV ejection fraction of 37%, way below normal, and he had significant, severe pulmonary insufficiency. I'm not going to spend a lot of time showing you the technique we use in the cath lab, but we take a picture, what's called the rotational picture. We do a 3D modeling of the outflow tract. We can do this real time in the cath lab, and then we can actually blow up a balloon where we're going to put the stent, do the same kind of pictures looking at the coronaries, and the coronaries are wide open, and then we can decide we can put a valve in that place. This is a patient who received the sapien valve because this required a much larger valve. And just to show you that we can do what we find sometimes, besides the valve, the patient had one pulmonary artery that was very narrow, which we stented. We then sized where we needed to put a valve, couldn't put a valve in there. That's why I like the sapien valve, because the sapien valve allows me to use much bigger valves, which are not available from Melody, so it's really added to our armamentarium. And we go ahead and put a very large valve in this patient, a 29 millimeter valve, which is the largest valve that's available. And this patient is doing extremely well. This is an example of how we can do this. So I'm just going to skip this in a matter of time here. Just show you how this has affected my practice and how we take care of our patients at Yale. It's the only group that we've studied this well to look at and show you what it's really done for our practice. And there's some things here to criticize what we've done, but I think you understand this, you'll see how it's really affected the care of these patients. From January 2007 to, it's actually 2016, the end of 2016, 172 patients were referred for pulmonary valve replacement in my hospital with congenital heart disease. This is for surgery or cath. Mean age was 18.6, so it ranges from 4.5 years to 65 years. The weight is from 12 kilos to 160 kilos. Most of the patients have Tetralogy of Fallot, which is what we're talking about today, but there are other smaller groups of patients that need the same kind of approach with a percutaneous valve. Of the 180 referrals in 172 patients, the primary indication was free insufficiency, lesser of pure stenosis, pulmonary stenosis, and mixed lesions of stenosis and insufficiency, but the most common is free pulmonary insufficiency. A complicated slide, but we'll just do it very briefly. We had 172 patients referred. 71 were referred directly for surgery. Some of them before we had valves, and I'll show you that data in a minute. 101 were referred to the cath lab. Of the 101 referred to the cath lab, attempted implantation in 85 and implanted successfully in all 85 patients. 16 patients we didn't implant. 11 because the outflow tract was too big, some of these before I had the larger valves. 3 because we had coronary compression and other problems that developed. But we did 85 patients in the cath lab. And this is what I find one of the most interesting slides, and I was surprised by this. We looked at the total number of valves, whether it's cath lab, surgery, that we pulmonary valves in patients with congenital heart disease for the last 10 years. We had sort of the same number going on from 2000 to 2011. And from 2011 to 2016, we almost tripled the number of valves we're putting in our patients. It means one of several things. One, we're doing too many valves. 2, we have an easier way of treating them, so patients are more likely to want to go through this than repeat open heart surgery. 3, we finally recognized how bad pulmonary insufficiency was and residual physiology was for these patients. And we had a technique to treat them without sending them back to surgery, so we went and started using valves. We've done 3 times as many valves. And you can see the last year, 2016, very little surgery. And this is the last group of patients we'll talk about, the ones so far we can't do it in the cath lab. And the reason for this is that we've got good techniques now on how to treat these patients right now. Now, the interesting problem is what the results have been. Just to show you what we can't do. These are 4 different groups of patients we talked about. Conduits, homographs, these are all circumferential repairs, these bottom 3. And we're able to implant just about every patient we can treat that. The patients with a non-circumferential repair, we only can implant a little bit more than half or maybe 2/3 of them because we don't have devices to fix these, which is what we're going to talk about at the end today in just a few minutes. But we're very good at doing this. We use the Melody valve for most of these patients, and the big areas we use the Sapien valve, but we're getting much, much better at this in our own institution. But to me, this is some of the real data that's brand new for us. We didn't realize this. This was brought to my attention by our echo group, who told us you really got to go compare the two because we're seeing a lot of problems with the surgical valves. So this is from freedom from regurgitation, freedom from significant pulmonary insufficiency. Since implant, the top line, the blue, is the transcatheter valves. Really, we don't have the same length of follow-up. But this is the surgical valves. It's a continuous downward curve. They all leak over time. And this is now out 9, 10 years, and we can see that it's very highly significant that the percutaneous valve is working much better than the surgical valve. And if you try to look at this from the same time frame, the same patients implanted, had surgery at the same time we had the valves available, we couldn't implant these patients, you still see the same thing. The catheter valves are working extremely well, and the surgical valves are not working quite as well. Why don't we reoperate on all these patients? These patients don't want to go back to surgery and go back again, and they're not terribly symptomatic, but we know long-term PI is bad for you. And you look, freedom from dysfunction, of any type of dysfunction, we're still very significant. This one drop in the catheter valves is actually one patient, because there aren't a lot of patients out at this point we have data on, but it's still going to be very significant, the freedom from any dysfunction of that valve. So what were our complications for this? And now I'm going to tell you the complications for the whole group. 11 of the surgically placed valves have been replaced already, 2 by surgery, and 9 of them have gotten Melody. So we can put a Melody inside a surgical valve. So one of the things we ask our surgeons now is when you put a valve in there, put a big valve in there so we can treat it with another valve. We had 1 Melody valve replaced with obstruction. That patient is a very complicated patient with lupus. And one of the big bugaboos people are talking about, and we'll go over that in a minute on the national scene, is endocarditis. So we looked at our patients. 5 patients in the surgical group have got endocarditis. Only 1 patient in the catheter group has got endocarditis, and that's in a sapien valve. And in the same time frame the valves have been put in with the catheter valve, surgical valve and catheter valve, we've had 2 SBE in the biological valve. So it's not just the transcatheter valves that get this, it's all of them. So having said that, let me just finish up by showing you the complications for transcatheter valves and what we're planning to do in the future for new valves. The biggest bugaboo in the beginning was stent fractures with the Melody valve. The stent is not as strong as we'd like it to be. It's got severe compressive forces in a hostile environment when you're trying to relieve obstruction. And we had a 14% incidence of stent fracture in the first 35 patients. Then the FDA allowed us to change the way we were doing it by creating a stronger landing zone by putting stents inside the landing zone. And now the incidence of this problem is less than 1%, and we think we've eliminated that problem. We've always had risks of conduit tear. That's always been there, but it can be serious. We now have ability to treat that in the cath lab since the FDA has approved the use of covered stents, which is material on the stent to control any bleeding from a ruptured conduit tear. Coronary compression, I showed you pictures of it. I've never seen it. There's been 2 cases in the U.S. I know with coronary compression. 1 caused the death, 1 was resuscitated. The biggest problem, the biggest amount of noise in the country is about endocarditis, and people have written articles that Melody valve is a much higher risk than any other valve for endocarditis. So it's really hard to get the data, and I'll show you what I know. Bioprosthetic valves all are at risk for bacterial endocarditis. These are surgical bioprosthetic valves. The incidence is, in the first 5 years, is 3 to 6% in all and this is as best as I can find in the literature. There is not a single article in the literature, prospective analysis, looking for SPE in surgical valves in the pulmonary positions. There's not a single article in the literature. No one has done that. While all our data is a prospective data, it's really hard to compare the results between the data, but there's not one in the literature. These are the transcatheter valves: sapien valve in the aortic position, core valve in the aortic position, Melody valve in the pulmonary position. They're pretty ugly looking. These are all patients who had to be explanted because of SBE. So what is the risk? I'll tell you what I know. The latest article that I can find this information on is freedom from endocarditis at 5 years in the Melodies is 89%, and for the Melodies about 87%. That doesn't come from an article. It comes from their instructions for use with their product that the FDA told them they had to write. So it looks like it's about the same. It looks like it's a little bit more than some of the surgical valves, especially the homographs have a lower risk. But that surgical procedures, and one has to balance the risk of SBE between the risk of repetitive valves. So let me just finish by telling you what I know, what we're going to do in the future. Remember I show you there are a number of patients that we can't put these valves in because it's just too big. Some of these are 40 millimeters in diameter. This is the PA, this is the right ventricle. They're enormous. This is a patient who's had a lot of other problems, another valve in another position here, but needs a valve in the pulmonary position. So what have we done? What have we learned so far? We actually have this comes from the University College of London, did work on this, and you can see did about 50, 60 patients, looked at the models of the different outflow tracts. All these outflow tracts are different. And if you go look at them in real time, look at this, they all work differently. Some of them compress up, down, some of them compress side to side, some of them have torque, like the one on the far right. So how do you design something that can survive in that kind of environment to make that work? So this is the work we've done so far. This is actually RVOT, looking at it using 4D CT. And what we do is you pick a spot in the right ventricle outflow tract, look at its change in diameter over time, look what it looks like. Then we go ahead and do that on multiple levels throughout the RV outflow tract. These are the kind of modeling that we do. See where it goes. And then you design a device that will not fracture, that will not be compressed, that will fit in these outflow tracts and be able to cover those outflow tracts. This is all done by modeling. And this is what it looks like. You put something in there that self-expands like that. You can have multiple different sizes. Unfortunately, we just have one size we've tested so far, and it works quite well, but it only treats a certain small percentage of the patients we need it to treat. And this is what it looks like when you put it in the RV outflow tract. This is all from modeling. Now, we've now done this in about 20 patients, where it's been 90% successful. But in order to get to those 20 patients, we had to go through about 70 patients to profile to get patients that would fit that criteria. This is what's coming down the pike. These are new percutaneous valves. These are different than the ones I showed you. This is made by Medtronic. This is made by, I don't remember the name of the company. It's made in China. This is the one made in the United States by Medtronic. It's called Harmony. It's a self-expanding system as opposed to balloon expandable. So this expands to fill a space, and it can fill different size spaces, but it's self-expanding to fill a space. So far, for those patients with the largest outflow tract, we have these self-expanding valves. We've tested in a research clinical in the U.S., the first research clinical done in the U.S., approved by the FDA for a valve design. And then we've just received approval from the FDA to start a larger multi-center trial, which we're going to be part of. So we're trying now. We can do about 70% of the patients, as you saw in the slide of the incidence. Our goal is to do as many more as possible. So let me just finish by saying the consequences for residual hemodynamic abnormalities following repair may be very serious. But we need to recognize them, and we need to know what we've done in kids has consequences 30 and 40 years down the line. And we need to take kids who are asymptomatic or 8, 10, 11 years old with free insufficiency and find a way to put a valve in them that would last forever or last longer than currently available valves. And that's what we're working on. That's what we're doing here. And we now have transcatheter valves available as an adjunct to surgical management. We're asking our surgeons, initial surgical procedure, to probably now maximize attempts to not give us those big outflow tracts and just so leave us with some narrowing, but not give us the big outflow tracts. We're asking for the patients who need to go to surgery, put in a large valve, put in a bioprosthetic valve, because all these valves I've shown you, we can put inside those valves when they fail, so-called valve-in-valve therapy. And therefore, you reduce the number of surgical procedures they have. So this is just, this whole story is a story of looking critically at what you do and the results of what you do, and you need a long-term vision to do this, because we are now changing what we're doing in the first decade of life totally because of what we learned following these patients 30 or 40 years. And the biggest increase in patient volume for me is adults with congenital heart disease. The babies are fixed incidence. They're the same number every year, but we're getting more and more patients as they survive and get older to make this work. So I hope you followed along with me, and I want to thank you for your attention. Thank you very much. Pretty close. Pretty close on time. Good. Yeah, thank you.
Thank you, Bill. That was a very nice presentation. Actually, Bill was my teacher, so I have to question him.
She was my fellow at Columbia.
At Columbia. So that's how I grew up. My question is about aspirin. As a pediatric cardiologist following these patients outpatient-wise, do you see aspirin long-term? 1, 2, does it decrease the risk of endocarditis? And 3, are these patients on SB prophylaxis for a prolonged period of time?
Initially, after we did valves, way in 2007, 2010, we followed routine guidelines for SB prophylaxis. In that, after 6 months after surgery, we stopped SB prophylaxis, and they were not put on aspirin long term. Since we now know there's a risk of endocarditis in these patients that is increased beyond higher than we'd like to see it, we've changed our regimen. Everybody stays in SB prophylaxis forever. And there's some anecdotal data out of Europe. The patients who are on chronic aspirin don't get SBE. I'm not sure I understand the relation between the two. Obviously, you don't want to get platelet aggregate that cause stasis. There are areas where infection develop. Remember, this is a very abnormal structures inside the heart, multiple abnormal structures, VSD patches, stents, valves. And when you put a valve in there, you're sort of blocking off the area behind the valve, and you get areas of stasis there. So we've now gone to do that. It's interesting, if you go look at the data out of England, SB prophylaxis has a lot of issues because it's never been documented to be effective, even though we used to do it. England, they stopped all SB prophylaxis. Their incidence of SB has gone up significantly in England, so they're revisiting now what to do with SB. So it probably does work. We just don't know in what percentage. So based on the anecdotal data out of Europe, that aspirin prevents or reduces the risk. Every one of our patients around the country now, the recommendation is they go on aspirin forever, one baby aspirin a day forever, and they all are on SB prophylaxis like you would for a mechanical valve in the aortic position. Yes, John.
Hi, thanks for a great talk. It's so great. Your story is awesome to watch and to see play out over years and what we've done. It seems to me that the future piece has two parts to it. One is clearly the technical piece. How do we get better and better and better at putting the right valve in the right place? But the second to me is also the timing. And it's predicting when people should ideally get these new valves. So do we have anything, it seems, from what I heard you say, there's a point at which the ability to remodel is lost. Do we have biomarkers or other ways to predict when that happens?
No. The short answer to that, I'm going to expand on that, but we don't have good biomarkers for that because we do not have a group of patients who we follow with certain hemodynamic parameters and put valves in some and not in the other. That has not been done. I'll tell you what I do and what other people across the country do. If we see anyone there between 8 and 10 years of age, totally asymptomatic, running around like crazy, but have a big right ventricle, I would do an MRI in those patients starting then. If the patient has a large volume with normal function, you and I can argue what a large volume is here because the number is all over the place in the literature. And they have normal function, so far we might wait in that patient if I can't get an adult-sized valve and if I don't think I can get an adult-sized valve in that patient. If the patient has an RV ejection fraction that is below the lower limits of normal by RV, again, making sure it's done properly because the surgery distorts the ability to measure that properly as well. I actually have put valves in those patients between 8 and 10 years of age, totally asymptomatic, because their volumes are over 150 cc's per meter squared, which is what we currently use, 140, 150, and their function is down. My concern, if your function is already down, waiting any longer, I won't remodel. I don't know if I'm right. I've been told I'm being very aggressive about this. But I think we know the risk, this procedure is very low risk, not zero, but very low risk. And if I have a patient whose function is down at 10 years of age, I would go ahead and put a valve in there, hopefully prevent further deterioration of functions and see if it will improve. I don't have the data to tell you that it improves yet, but still collecting that data. So we haven't had a group with changing bioparameters and then put the valve in one and then put the valve in the other. I'm not sure that's ever going to be done, by the way. But I think it would be useful. That's the only way we're going to get that data to look at. The only markers that I'm aware of is function and volume to look at it.
Other questions?
Shanti? Yeah.
My question is about the ventricular volume and the risk of arrhythmias. Do your center, do they perform an EP study during the cath, or what is your recommendation?
You know, it's an interesting question because I gave a similar presentation at DC Children. Charlie Burrill asked me, how come the risk of sudden death and arrhythmias has not gone down with the use of percutaneous valves? And I have a very simple answer to that. We wait way too long to put those valves in those patients. The problem is that group of patients he's referring to get their valves when they're in terrible shape with their New York Heart 2-3, and they really have not improved. So we do not routinely look for arrhythmia before we put the valve in there. What we will do is look at it after we put the valve in there, because I don't think it makes any sense to me to do it beforehand, because we're going to decide to put a valve in and see what they're like afterwards. We're not going to go after that area right now unless they have clinical VT, let's put it that way. So we do not study those patients. We might study them afterwards. We have done that, not consistently, but we have done that on patients who've had on Holter's non-sustained VT, 8 or 10 beat runs of VT, but we don't do anything then until we do the valve place. That's also one of our other indications to do a valve as a patient with VT, non-sustained VT on a Holter, is that we would do the valve and study them again 6 months later, and if we thought we needed a defibrillator, we put a defibrillator in. But we do not do it ahead of time unless they have severe clinical VT. Yeah. Hi.
Hi. Just saying, Shanti was talking about you being her professor and you are a proctor putting her first valve in. I have a comment and a question. I think moving forward with these valves, we're all facing the sort of a conundrum, in fact, that when you discuss the volumes, and I kind of go along with yours, that if the end-systolic volumes are high and the function is down, you should do the valve irrespective. However, the counterpart to that from cardiologists and surgeons will be, well, you're putting a valve in, the clock starts ticking. Now, you may not be able to do valve in valve, and the patient, if they live 80 years, will end up with potentially the same number of surgeries/procedures. So how do we balance that moving forward without having data? Because if I look at your data, 2011-12, number of valves, surgical or percutaneous, went up, probably because you found all these patients with the volumes of 200 indexed, and now it's like, well, we better do something about it.
There's no answer to your question to make it work. I believe every one of these Melody patients can have a valve and a valve. I think there's no limitations to how much you can stretch it as long as the coronaries aren't close to where you're putting it in. And I think the sapien valves that are going in, which are much larger valves, you can always do a valve and valve. So I'm not sure your premise is correct. I would agree with your premise that you can't put valve and valve and you're going to do the same number of surgical procedures. I think you're still going to delay the need for surgical procedures. What I'm afraid you're doing, though, is not operating on a patient when they need to be operated on to prevent progression. And to me, that's the important factor, not the total number of surgeries or the worry where you can do a valve and valve. What's nice about the Melody and or the sapien, you can do a valve and valve in those patients. So the next procedure can be a valve. There are a number of patients that have had valve and valve already, but only a small number. This is a bioprosthetic valve. I love the function of this valve going out 6-7 years, but this is a bioprosthetic valve. It's going to fail. By definition, it's going to fail at some point in time. It's working better than our surgical valves in situ right now, but it's going to need to be redone. And I agree with you, the clock starts ticking again, but I believe you can still decrease the number of open heart surgical procedures. We got a lot of, I'm getting out of this business in another year, so you guys are going to have to find this data very soon.
Maybe like one other comment, Bill. One of the things that I've seen in our adult congenital patients, which due to my advanced age, I managed to see a few of, that they have problems that are not directly hemodynamically related to systolic function and volume load, but rather to diastolic dysfunction, where they have markedly elevated left ventricular end diastolic pressures, not because the septum is displaced, but because the diastolic function of the left ventricle is poor. And whether this is related to techniques of cardiopulmonary bypass and myocardial preservation in early days or something else that we just don't understand, I don't know. But unfortunately, we don't have a valve or a drug that's going to treat that.
Yeah, but those particular patients, we see a lot of that in patients come in with very big RVs, with poor function in the RVs. So we'll aggressively go after the valve on that side and see if possibly it's some crosstalk between the two ventricles that you might improve putting a valve in there. All the more reason to do this earlier rather than late, but that data is 10, 15 years down the line. Thank you all very, very much. I enjoyed it.